without any morphologic abnormalities, and this is the type that is considered to be associated with IBS with diarrhea or functional diarrhea. And type 3 is results from GI disorders that affect absorption, like small intestinal bacterial overgrowth, celiac disease, chronic pancreatitis. And then there is this fourth category. It's not a type, but it's a category where the patient has excessive bile acid synthesis, even though their reabsorption is not impaired. That can happen with hypertriglyceridemia or with patients on metformin or other agents. So one thing that people have been thinking about recently is, are these patients with IBS with diarrhea or functional or chronic diarrhea, really do some of them have bile acid diarrhea, which we would treat differently? So there's a test that you can measure bile acid diarrhea, and that's the CCAT. We don't have that in the United States, but it's used in Europe. But it's basically an analog of bile acids given to the patient, and then you will wait 7 days and you'll measure if they have bile acid that's retained. But patients will have an abnormal CCAT study if they have bile acid diarrhea. And they use that in Europe to guide whether they're going to put them on a bile acid sequestrant. Now at Mayo Clinic, they developed a test called a 48-hour fecal bile acid test, where you have to collect stool for 48 hours. You have to be on a 100-gram fat diet, and then you send it, and they measure primary fecal bile acids and as well as total fecal bile acids. So the question of their study was, what's the prevalence of bile acid diarrhea? Are the demographics and symptoms different between those who have chronic functional diarrhea and those who have diarrhea due to bile acid diarrhea? What are the diagnostic tests that were completed before the bile acid test, which I'm not going to go over in the interest of time? And what were the outcomes of treating these patients with bile acid sequestrants? So Michael did a study previously that was just recently published in CGH, looking at what are the thresholds with the receiver-operated curves of fecal bile acids, total and primary fecal bile acids in their 48-hour study. They looked at 24-hour as well, and what they were basically trying to do is find thresholds. So if someone sent in their samples, they would say, okay, this is abnormal, and this is suggestive of bile acid diarrhea. So they used these thresholds, and they looked at their database of patients. So there was over 1,000 patients that presented. Okay, of course, this is Mayo Clinic. This is Mayo Clinic Rochester, which would be a tertiary care referral center with chronic functional diarrhea, who had the 48-hour fecal bile acid study. They excluded these patients that you can see here on the left, and they had 936 patients, and they measured bile acids. And they found that 51% had increased fecal bile acids. And you can see the breakdown of these 51%. A little over half had primary fecal bile acids, and then the 43% was total. So when they compared their cohort to previous studies, and this is a systematic review, they found that there was a similar number of patients, a prevalence of patients or proportion that had bile acid diarrhea. So it's estimated somewhere between 25–30% of patients with chronic functional diarrhea or IBS diarrhea actually have bile acid diarrhea. But they actually found more who had also the 51% that either had a total number of bile acids that were elevated or just primary fecal bile acids. So what they did, and again, this is not a prospective study in the way that probably it should be done, and I'm sure they'll do that in the future, but when they looked at these patients, of this 51%, some of the patients were treated with cholestyramine, that was 38%, and some of them were treated with colesevelam. That's 45%. And you can see the follow-up was about 50% of the patients. So you don't have follow-up in everybody. But of the people that they had follow-up in, about 71 to 75% actually had improvement in their diarrhea with a bile acid binder. So they concluded that 51% of their patients with non-bloody chronic functional diarrhea had bile acid diarrhea. When they looked at the patients who had increased fecal bile acids and those who didn't, they really didn't see a difference in their profiles. So you couldn't really tell who may have it and who might not. And then they used a 48-hour fecal bile acid diagnostic testing, and they said that it can reduce healthcare utilization because a lot of these patients had multiple diagnostic studies that were negative, so they were not helpful, and that you can individualize care by identifying those with an increased probability of responding to bile acid sequestrants. I think the issue with this study, though, is that it's hard to get patients to give one fecal sample and to actually do 48 hours is challenging. So in clinical practice, they're trying to determine if you can do a spot stool test, or if you can use C4. So C4 is a serum blood test that gives you a measure of hepatic bile acid synthesis. And so some people can use that. It has a 74% positive predictive value, but it has a high negative predictive value. So if it's normal, it's unlikely the patient has bile acid diarrhea. But right now, I think in practice, often we just give them a bile acid binder and see if they improve. But I just want to show you some of the data so you'll know that, or that you might want to consider in some of your patients with chronic diarrhea that they might have bile acid diarrhea and you want to treat them differently. So again, this is a tertiary care referral. They didn't have any direct comparison to CCAT, which is the gold standard. They looked at outcomes that were available in medical records. They had to retrospectively go back and look at the data. They have no probability modeling, so it really needs to be confirmed in a prospective setting. In general, if you ask experts in the field, they think about maybe 20%, the most, will have bile acid diarrhea. Okay, so I'm going to move to the second topic, which is cannabinoid hyperemesis syndrome, and trying to define the diagnostic criteria. So you probably know there's CB1 and CB2 receptors. The endocannabinoid system consists of these two receptors and the ligands and the enzymes that break them down. And so these are the two ligands. So they're anandamide and 2-AG. So a THC will act predominantly on CB1 receptors, to some extent on CB2. CB1 receptors are mainly in the brain and spinal cord. CB2 are in the periphery, a little bit in the central nervous system, but they're on immune cells and the enteric neurons and also in the epithelium. So the CBD actually does not directly act on either CB1 or CB2, but it enhances the effect of cannabinoids on CB1 and CB2. And so I just wanted to let you know of just this endocannabinoid system to explain about how this system plays a role in the control of nausea and vomiting. So if we look in the brain region, particularly in the brainstem, and also in the cortical regions. The CB1 receptor is the predominant receptor in the brain. If you act on the CB1 receptor, you will suppress serotonin to be released. And if you have less serotonin, then it won't act on the 5-HT3 receptors to cause nausea. As you know, one of the main treatments for nausea is a 5-HT3 antagonist, that's ondansetron, and that's why it works. But if you act on the CB1 receptor, you release less serotonin. And that's why cannabis can help reduce nausea, and even the THC drug dronabinol. It's not really clear why, if you use a lot more cannabis, why you will develop a cyclic vomiting syndrome. That's not really been known. There's some evidence that there may be some genetic predisposition, like potentially with a cannabinoid receptor polymorphism, or that you're making more of these ligands and you're desensitizing the CB1 receptor, and if you desensitize it, then you're not going to suppress serotonin release, and you're going to act on the 5-HT3 receptors and cause nausea and vomiting. There's also some potential evidence that they make more metabolites, and certain individuals are predisposed to getting CHS, cannabinoid hyperemesis syndrome. So the Rome 4 team came up with a cannabinoid hyperemesis syndrome. This is the diagnostic criteria just based on some evidence that was available. So I'm sure you're very familiar with cyclic vomiting syndrome, where you have these very stereotypical vomiting, repeated episodes, last anywhere from 1 to 5 days. In between episodes, they feel very normal, and it happens at least 3 times per year. The only way that you can differentiate this CVS from CHS is that the patients are on cannabis, and their symptoms will go away, resolve if they stop cannabis. So this group of investigators were trying to look at all the data that was available to determine what are the diagnostic criteria for CHS. And this is going to be more of a problem, as you know, because marijuana is getting legalized in many states, including California. So we're probably going to see a lot more of this, or we're going to be thinking a lot more of it. Okay, so cannabinoid hyperemesis syndrome mimics cyclic vomiting syndrome. The prevalence is not really known. There's some inconsistent diagnostic data, but it's thought to be less than 10% of people with these symptoms, and maybe up to 3 million Americans. So there is a CVS group, this association, and there's the American Neurogastroenterology and Motility Society, ANMS, and they got together and they developed a CVS Practice Guidelines Committee, and this is their study. So these committee members, they completed a survey to try to reach a consensus on what they thought the diagnostic criteria should be for CHS, and they also looked through published cases over 14 years to try to get some evidence to help support what their consensus was. So what they decided was that the features of CHS were that you have a stereotypic pattern resembling CVS. The presentation after cannabis use, patients were usually on it for at least a year, and they have to use it frequently. And they decided it has to be at least 4 days per week, and consuming at least 15 to 20 doses per week. Typically, a patient is taking it multiple times during the day. Symptom resolution has to be with cannabis. Now, this is where they were trying to determine how long do you have to test a patient off cannabis to see if their symptoms go away so that you can say they have CHS. And it really has to be prolonged. So they said, based on the data that's available, it has to be 3 months at least, or at least making it through 2 of their cycles of vomiting. So say a patient has vomiting every other month, you'd have to be on it long enough so that you see that you bypass 2 episodes. So really their CVS symptoms are due to cannabis. So they had 405 patients. They looked through all these cases. You can see that they had at least 3 episodes per year. They had more than 1 year of use. 78% did not meet the Rome 4 criteria, and it was basically because they either didn't go off the cannabis or they didn't go off long enough to determine if their symptoms went away. So they just said that it is an entity, there's incomplete details. They had a consensus definition, but they really need more precise data collection, and there really has to be future prospective studies with greater rigor so we can really characterize what's the actual defining diagnostic criteria for these individuals. The third topic I want to go through is this avoidance restrictive food intake disorder. It's starting to be really well recognized, and it's called ARFID. And it actually has DSM-5 criteria. There was a few abstracts. I'm going to pick one by Bill. I'm going to show this first, then I'll pick one by Bill Chase Group. This is what we did at UCLA. I'm just going to show you a couple of slides I did with Adrian Leonard, who's one of our GI fellows. We wanted to look at the diet pattern in IBS patients. And we basically found that there were a subgroup that had dietary restriction. We were interested at finding that a lot of our patients were not on low FODMAP diet, and I think it's because we took community individuals. We didn't really take the tertiary care referral, or they were on it for a brief period of time. But we found that when you see IBS patients, you're going to find there's more that have these restrictive diets. And so we looked at usual symptom severity and found that the more severe their IBS symptoms, the more likely they were going to be on a restrictive diet. Women were more likely to go on a restricted diet than men, and then those who had increased GI symptom-related anxiety. So they had anxiety related to their GI symptoms, and they also had a decreased health-related quality of life. So ARFID actually has DSM-5 criteria. It's when the patient is avoiding or restricting food intake, which can be based on lack, they're just not interested in food, or the sensory characteristics of food, or this conditioned negative response that if they eat food, they will have a negative experience. And this eating behavior leads to persistent failure to meet nutritional and or energy needs, and it's manifested by at least one of the following. They have clinically significant weight loss, or in children, this has been described more in children, they have a failure to thrive, nutritional deficiency, supplementary enteral feeding or oral nutritional supplements, just so they can have adequate intake, or they have impaired psychosocial functioning. And it's not due to a lack of food. Whoa, what happened? It's not due to lack of food or to a cultural practice, and it's not due to a classic eating disorder of anorexia or bulimia. They do not have a distortion in their body image or shape, and it's not due to a general medical condition or other mental disorder. Sorry. So this is the study by Bill Chase group, and basically they wanted to look at ARFID and this eating disorders in patients in their tertiary care referral center who had seen a behavioral medicine, so a health psychologist. This is, I'm sorry, I'm pressing the button and it won't go forward, and then it goes forward twice. Okay, so their hypothesis is that ARFID is an under-recognized disorder among GI patients referred to GI behavioral health providers because it's thought to be associated with a psychiatric disease. So they did a retrospective analysis of a prospectively developed database. They had 223 adult GI patients who had been seen by GI psychologists at tertiary care referral center, and they based the diagnosis on retrospective chart review. And they looked at clinical data. So they found that 12.6% of their patients met the ARFID criteria. You can see the mean age, most were women. They had a normal BMI, but you can see the BMI range was pretty large, and the mean weight loss was 19 pounds. So if you see the left side, you can see that a fairly high percentage of these patients, and this is only 28 patients, had multiple GI symptoms or they had actual diagnoses, so abdominal pain, diarrhea, constipation, IBS, and even GERD. When they looked at the psychiatric diagnosis, but they only looked at anxiety and depression, it was relatively low, it was 18% for both, so it wasn't as high as I think they thought it would be. Of those patients, 89% were referred to nutrition. Of course, Michigan is very focused on dietary modifications in these patients. So it's not surprising they had a high referral rate. But prior to nutrition referral, 74% of them tried a formal diet plan. 89% were prescribed a low FODMAP diet by their GI. 71% were prescribed a low FODMAP diet even though they met the ARFID criteria and they had weight loss. 43% were on a gluten-free diet, 39% on a lactose-free diet, and almost 70% were self-driven change or restriction. They imposed it themselves. And in none of these patients was ARFID ever mentioned in their medical records. So this is limited, it's retrospective. They didn't screen for all the ARFID criteria. They just try to get what they could from the medical chart. It's a smaller sample size, tertiary care. They're very focused on the dietary management like low FODMAP at Michigan. But their conclusions were that although ARFID is often associated with psychiatric disorders, only 28.6% had a prior psychiatric diagnosis. And ARFID can complicate the clinical presentation of GI patients. It's an under-recognized disorder, even in a healthcare system where they're focusing on these kind of disorders. And it raises concern regarding need for judicious patient selection when you prescribe restrictive diets. And I have to say that I see this more and more. Patients are just eliminating, and sometimes they don't even have a consistent association with their symptoms, but they don't want to restart it because they think that if they restart it, that their symptoms will come back. So thank you so much for your attention. I'll let Ali speak.